So they asked me to talk about surgery for spasmodic dysphonia, which, I don't know, is a difficult thing to talk about, mostly because for many, many years, surgery was kind of an anathema to patients with spasmodic dysphonia, primarily because before Botox, you know, when Dr. Dito did his surgery and actually helped many, many people, after they went out, maybe about 5 years or so, many of them recurred for a variety of reasons that maybe we can get into. So it became kind of like a no-no. And clearly Botox, when it arrived, was a remarkable improvement in the lives of the patients that had this condition. But you know, if you really think about it, is Botox a permanent solution or is it an intermediate solution? And I would probably argue that for patients that have spasmodic dysphonia, it's a wonderful intermediate solution. But if you have to carry out injections for the rest of your life, there are certain things that happen. And one of the reasons that Botox sometimes stops working is it becomes more difficult to inject patients. You know, every time you poke a needle in there, you get a little bleeding, you get a little calcification. And after 20, 25 years of poking them, it's very difficult to do. Having said that, you know, I've had patients that I treated with Botox. I have many, many patients that I treat with them for many years, and they seem to do well. And so I don't really talk to them very much about surgery. In fact, I don't really mention surgery at all to them. These are some of the reasons when we looked at 81 patients that decided that they wanted to not continue with their Botox shots, and not all of them are from Los Angeles. We obviously have patients from all over the United States that come to us. The cost, you know, Botox is not inexpensive. If you total up a lifetime worth of Botox, you will find that it is far more costly than any operation that you could offer to a patient. I hate to use the expression, but it's really an annuity to doctors that use it. Botox stopped working. Botox never worked. That's kind of hard to believe. I had a lady once that came to me around Christmas time and said, "Can you give me a Botox shot?" And I said, "I'm in town here." I said, "Well, how much do you need?" She said, "I need 100 units. And I kind of went, I said, 100 units? She said, "Yeah, I've actually developed antibodies to Botox, and so it takes an entire bottle of Botox to get a response." And I gave her 100 units, and I thought, oh my God, what am I doing here? And she got a little bit of a response to it. But as Gail alluded to, it happens very, very rarely, almost never. And now they do have a Botox B that you can use if that occurs. So a surgical analog of bilateral Botox injection. So there are basically a number of surgeries that, and I don't have a super amount of time here, so I'm going to have to go through this very quickly. Almost all the surgeries on the thyroid cartilage that have been developed for spasmodic dysphonia were probably developed by a really smart plastic surgeon in Japan by the name of Dr. Ishiki. And I'll talk a little bit about that. Some people can actually cut the muscle that's in spasm, and we call that a myomectomy. And then, of course, re-innervation and de-innervation surgeries. So as you know, I have a bunch of different drawings of the larynx here, but I think what I wanted to point out, I don't know where the pointer went. Oh, there it is. Thank you. That there's really only one muscle that opens the vocal cord, and all the other muscles that are inside of the larynx actually close the vocal cords. There are adductor muscles, and there's one muscle that, of course, opens the vocal cords that allows us to breathe. And as mentioned, Botox doesn't act on the muscle. It actually acts on the neuromuscular junction and inhibits the release of the acetylcholine, which is the neurotransmitter that actually causes the muscle to contract. And as mentioned, the body has to go ahead and synthesize new motor end plates, and when it does that, it takes a while for it to do that. And in fact, Botox, as you know, doesn't really work immediately. It takes a couple days usually to start working, which is interesting because I don't think anybody knows why. So to kind of push through this, laryngoplasties were thought to maybe reduce the tension. And there's two types of laryngoplasties that have been popularized, mostly in Japan, where, by the way, spasmodic dysphonia is a very rare condition. I'm not even sure it exists in that country. One was actually to push the front of the larynx back, and we call that a type 3 thyroplasty. And of course, when that first came out, we did that, and what I found was that it really didn't work. After scarring occurred and healing occurred, the patient's symptoms came back. But what happened that was really disappointing was you had to put like a little splint in there to keep the cartilage from coming back. And between that and the scarring, the patients were almost impossible to re-inject with Botox. So you had a surgery that frequently, at least in my hands, didn't work, and it made it almost impossible to inject them with Botox afterward. Then they shifted to another operation where they actually would widen the cartilage, thinking if you widen the cartilage that the vocal cords won't be able to go into spasm, which unfortunately didn't work as well. And the shim that they put in to do that additionally makes it almost impossible to re-inject patients with Botox. I did want to spend a minute on medialization thyroplasty for abductor dystonia, because I think it's an interesting proposal and does have some potential. I've just put up here that SD is not a cartilaginous problem, it's a neuromuscular problem. So when we talk about thyroplasty, type 1 thyroplasty, we're actually pushing the vocal cords together. And a number of years ago, tried that on a series of patients and found that for those with abductor dystonia, and I'll show you the data quickly, for those with abductor dystonia, it actually helped them quite a bit as long as they didn't have a really severe case. If they had a really severe case of the abductor dystonia, really nothing, unfortunately, that we have in our armamentarium helps them. But for patients with mild to moderate abductor dystonia, it actually helped them quite a bit. And so we went back over a 10-year period and kind of looked at some of our patients to and interviewed them. And we had them fill out a quality of life and a vocal handicap index. And when we looked at the results, and I was actually quite surprised about this, we found that it was grossly statistically significant, that the patients that had undergone bilateral thyroplasties did much, much better than they had before that. And you can see some of the comments here. These are people, I avoid going out socially. All of these are at a 0.004 level. And for those of you that are familiar with statistics, that's really significant. And the same thing for the voice handicap index. It was really quite significant, except for talking on the telephone. I think some of them still had some issues with, which is not too unexpected. We had a very small cohort that we were able to find and interview. So I would say that for patients with mild to moderate abductor dystonia, then the good news about that is any really quality voice center, and certainly Vanderbilt is one of the best in the world, can do bilateral thyroplasties on patients. You don't have to fly out to Los Angeles to do it. Almost any laryngologist that has familiarity with these types of operations can do it in your hometown. So it's something to consider. What else did I want to say about that? How it works, I'm not entirely sure how it works. It would be nice to maybe do a study, but I have a feeling it has to do with sensory feedback and stiffening the vocal cords, so patients just use more force to try and get the larynx closed in order to communicate. Obviously, this was a retrospective study and not a prospective study. So myomectomies, the people have talked about cutting the muscles, and certainly there have been some procedures to do that. part of the problem with cutting the muscle is it's hard to know exactly what the end point is, and then once the muscle is cut, you're not actually changing its stiffness if it grows back together again, and they can have a lot more hoarseness in their voice just from cutting the muscle. For PCA cutting for abductor dystonia, it's, again, very hard to know where the end point is because we obviously need the PCA muscle, which is the muscle that's primarily involved in abductor dystonia in order to open our vocal cords to breathe. So you really never know exactly how much to cut. So it's a very difficult problem to treat in that regard. I'm kind of rushing through these things. The good news is that the muscle, the nerve, I should say, that goes to all the adductors runs right underneath the thyroid cartilage. And I sometimes jokingly say, God in his infinite wisdom put that nerve right under the thyroid cartilage so that maybe we could find that nerve if we need to treat patients with this procedure. There have been other attempts at de-innervation and re-innervation procedures. You know, as I alluded to, Dr. Tito was the first person to actually cut the nerve and actually helped a number of patients. And he actually was the first individual that was able to say, no, this is a neurologic problem. This is not a psychogenic problem. These patients actually have. So we need to give him a lot of credit for that. But as I said, you know, many of the patients recurred because he could only treat one side. You can't cut the nerve on both sides. And then many of the patients underwent laser vocal thinning to try and improve the results, which resulted in pretty bad voices, even on top of some of the recurrence. Dr. Nashville, who hangs around here somewhere, I don't know, wrote a paper about avulsion of the RLN to prevent regrowth of the RLN. But he reported that there was some unpredictable breathiness that occurred. And then when he medialized them, some of them had return of their symptoms. Again, it's a unilateral procedure, one side. There was a doctor in Japan named Iwamura that did unilateral selective RLN section, but he didn't re-innervate them and got pretty good results. But again, information from Japan, because SD is such a rare disease there, is hard to really understand. So this surgery was basically based upon an understanding of the neuroanatomy, and really it's surprising that the intralaryngeal neuroanatomy of the larynx really had not been described until about the 80s. I mean, can you imagine gross anatomy? And it's a gross anatomy, but nobody had ever taken the opportunity to really look at the inside of the larynx and see how it's structured. And really, if you do that, you find that, and again, I don't have a lot of time to talk about it, but you can actually locate this intralaryngeal branch, that is the adductor branch that goes to many of the adductors of the larynx surgically. And of course, you know, there's a lot of people that say, oh, animals are a waste of time, but this was all worked out in an animal model, and these animals gave their life, I think, so that we have the opportunity to maybe just develop this procedure for human beings. And, you know, they really, I don't know, every time I think about that, it gives me shivers just to think of what they've done for us. So the first study, as I said, that we did, showed that if we cut the nerve that goes to the adductors intralaryngeally and we re-innervated it, it didn't matter how much stimulation we gave to the nerve. We could never get the animals that we have a way of phonating to go into spasm. The larynx would close and it would vibrate, but it would never go up to the level of spasm that we hear in spasmodic dysphonia. And you can see that was done back in 1992. And believe it or not, in Los Angeles in 1992, there were patients that couldn't get Botox. In the county hospitals there, none of the patients were able to get that medicine. And so these were some of the first patients that we decided, well, maybe this might be an advantage to try this on them. And as you might imagine, transferring it from an animal model to the human took a lot of study and re-looking at what we were doing. But those were the first times we did that. And here diagrammatically, you can see that what we do is we make a little trap door that you can see in the back of the larynx there, and we flip the little trap door down, and we find the nerve, and we cut the nerve, and we graft on a nerve that's not involved in the spasm. It's a nerve to one of the strap muscles in the neck. And we do that on both sides, and it allows the muscle, the primary muscle that we inject Botox into, to kind of like re-innervate with the nerve that's not involved in the spasm. And we do that on both sides. And this is the answer. It goes to 8 strap muscles in the neck, and we take one that's a very standard nerve that's been used in re-innervating the larynx for quite some time. So the first patients were in 1993. Because of Dr. Guido, we actually had to wait really 5 years before we presented our results, because people would just say, oh, these aren't going to hold up. So I think 1996 was our first report on 21 patients, and 19 of them really had pretty good return of their vocal function after that. And I encourage you, if you're really kind of interested in it, to go to the NSDA website or Facebook. You can read many patient reports of how the procedure works. And by and large, it seems to help a number of people. This is just a diagram showing where the forceps is up here, that we identify the nerve. We put a suture around the nerve, and then we cut the nerve. You can see the arrow points to the little end of the nerve that's sticking up, and then we take the bantha and we microvascularly do a microvascular anastomosis on both sides. The operation takes about 2 or 3 hours. So these are some of our really early results, and I'm just going to run through them, but basically many of the patients went from a voice handicap index score of 35 down to 12, which is anything more than 10 is usually considered pretty significant. And 83% of patients had at least a 10-point change. This is some of what the pie graphs look like, and some of the data on my speech is more fluent. I still have vocal spasms when I speak. You can see they went down. There have been changes to the technique. Certainly in males, males actually have to be able to close the very back of their larynx in order to talk, and so we had to revise the surgery. And we've actually been revising it more or less over the last, I would say, 20 years that we've been doing it, to the point now where I think we have it down to a pretty easy thing to do, and something that I think anybody that comes and visits us can learn to master. Unilateral versus bilateral. So most of the patients that we operate on probably have about 3 to 6 months of breathiness. It's like, I used to tell them, it's going to be like a big, huge Botox shot. But for patients that actually can't endure any amount of breathiness for a variety of reasons, their work won't permit it, or they're just not ready for that. We have done unilateral procedures, and just one side, and we've done about at least 15, maybe 20. We've actually wrote a paper on it, which was published, but what I can say is that about half of them needed to have the other side done. And these were patients that probably had a little bit more severe dystonia than other patients. But we have found if we do the other side on an interval basis that the results were the same. Basically, they still got a relief of their spasms. So who's a candidate for de-innervation, re-innervation? Patients with primary adductor spasmodic dysphonia. Who's not a candidate for de-innervation? Certainly, 3 hours can be a long operation for some people, although surgery is difficult sometimes, and sometimes it's much easier. Mixed dystonias are a little bit harder to do, and certainly patients with tremor we worry about, because although sometimes, as alluded to, there's a lot of varieties of tremor, the tremor can be much better, but the tremor can actually be more prominent. So it becomes a decision on the patient of whether they're willing to substitute spasm and tremor for just tremor alone. These are obviously good results, but I thought I would just kind of play them because I think they're kind of illustrative.
Well, I worked in Eric's office, very, very difficult. My work's now taught and breathe and Botox.
Pretty bad dystonia. So this is 53 months.
I got Spasmodic Dysphonia several years back. I was the secretary at the time. Very, very difficult to be on the phone all day, talk to people all day with no voice. I got...
Okay. Actually, it started when I was skiing, believe it or not, and I noticed I dropped about 4 notes off the top of my range.
And then
I noticed it the first time actually because I was a singer, and what I did was I was leading music in a church service.
so you can see that in a number of patients, they get extremely good response from that. As I alluded to, tremor is kind of an unknown factor. Some get better, some don't. You know, nerves don't reinnervate as well after about the age of 70. And so, unfortunately, for a lot of patients that have dystonia that are greater than 70, they're probably not good candidates for this surgery just because I don't think that they're actually going to do that well in terms of the reinnervation and the potential for their symptoms to come back. Although, for the patients that do fail the surgery, they can go back to Botox shots. So it's not a one-time deal. Typical, believe it or not, most patients nowadays go home the very next day. We keep them overnight. The next morning, we kind of go over swallowing with them because it's, you know, they have quite a bit of breathiness, and it's just like with a big shot. Once we're convinced that they can swallow adequately, we let them leave the hospital. 1 month, voice is breathy, 3 months. Some take up to 12 months to really get maximal improvement. So there's a lot of variability in human beings. So just in conclusion then, you know, there's a lot of manifestations of SD, and so it's important that you make sure that, you know, that you're getting a proper diagnosis. There's a variety of treatment options. I think Botox continues to be the preferred primary treatment for it. I think surgery and Botox therapy can have some adjunctive treatment in abductor variety, and obviously there's a number of critical factors that come into concern. So that's really all I have to say. Thank you so much.